to continue our book club on the radiologic anatomy with our colleague Dr. Iman. She will talk about the liver and spleen. May she proceed? Start.
Assalamu alaikum. I will talk about liver and gallbladder. Liver is the largest organ in the body, and it's
First
more
of all, skin is the largest organ in the body. Liver is the
visceral
second
organ.
largest. Visceral organ, okay, but the skin is the
Visceral
largest
organ.
organ in the body.
It's largest visceral organ in the body, and it's like right hypochondrial area, and it's more large in fetus and child than the adult, according to the body size. It has two surfaces, visceral surface and diaphragmatic surface. Diaphragmatic surface, it lies about, it's flat, smooth, and covered superiorly and anteriorly by the diaphragm. It has two dome, a largest dome for right lobe and a small dome for left lobe, and separated by a notch slight for central tendon of the diaphragm. And inferiorly, it has two notches, the first for gallbladder and the second for round ligament, or what's called ligamentum teres. It's obliterated left umbilical vein. It's carry blood from placenta to the fetus and obliterated in the adult life. And it's continuous run in the round ligament and falciform ligament with paraumbilical vein also in fetal life. Falciform ligament is a free edge of fold of peritoneum that attach to the slide to the right of the midline of the liver, and this is the visceral diaphragmatic surface. The visceral surface is an H-shaped structure, what we call the first right limb of the H shape. It's formed by gallbladder bed and the gallbladder and porta hepatis, and anteriorly, posteriorly by inferior vena cava. Between these two, separated by caudate process, and also the caudate loop to the left of inferior vena cava. The left edge structure, edge limb of the structure is formed by ligamentum teres anteriorly in the ligamentum fissure, ligamentum teres fissure, and inferiorly ligamentum venosum fissure, which contain ligamentum venosum, is a remnant of ductus venosus in the fetal life, which carry blood to the inferior vena cava in fetus. There is
From the inferior vena cava, the other connection is to where?
Inferior vena cava.
Okay, it's a tube. Here, inferior vena cava. What's here? Shift the blood from here to here. Okay, this is the IVC. What's here? The other end.
Ductus venosus.
Okay, what's the other end? And here, tube, vein, carries the blood from somewhere to somewhere, from somewhere to IVC. What's this?
Placenta in the fetus.
From the left branch of the portal vein.
That's right.
Left branch to the IVC. So it is like a congenital tips. You know tips? Transjugular intrahepatic portal syndrome. Congenital. From God, it shifts the blood from here to here. When the baby is giving birth to a baby, this tips will occlude and will go into adult circulation.
Even in ultrasound, we see the left portal vein, and the continuation of it will be ductus venosus.
Again, it is
That's
on
right.
the YouTube presentation on the YouTube channel. You can see how to find
this
it.
picture is inverted يعني.
Yes.
From
طبعا upside
inferior.
down.
But when you يعني explain, you said that the gallbladder superiorly and the inferior vena cava
Anteriorly,
when
not
anteriorly.
superiorly,
Yeah,
and
because it's upside
posteriorly.
down.
And from downward we
Yeah.
see it. There is liver is in contact with multiple viscera. There is and make multiple impression. There's gastric impression and esophageal impression on the left lobe, and on the right there is a colic impression anteriorly and behind right kidney and right suprarenal area. And there is a area of peritoneal free area in the posterior of the liver. It's called bare area of the liver, and it's bounded by a coronal ligament. A few points about radial loops. It's a relatively common variant. It refers to inferior elongation of a segment 5 of right loop and as an extension to
Six.
6 loop to the
Segment 6
segment
of the right lobe.
of the right lobe is extend to the lower pole of right kidney, may be accompanied by a small left lobe. It's possible, and it's clinically important because it make a palpable abdominal mass and it's normal variant.
First of all, is it more in female or in males?
Females more common,
It's more
9
in
to
females.
5 to 10%.
Okay, it's tongue
Rare
like
tongue-like projection.
from the inferior border first. Second, usually when you have a Rydell's lobe, you have a small left lobe. When you don't have Rydell's lobe, you have a big left lobe. So it's vice versa. Don't. When you see a Rydell's lobe and you see left lobe small, don't think of some disease process. It's just normal.
Yes. A few points about caudate lobe before I enter to the segment of the liver. Caudate lobe is segment 1 located posteriorly. This is the caudate lobe, that's right. The caudate lobe is anatomically different from other lobes of the liver. It has a direct connection to the inferior vena cava through the hepatic vein and are separated from the main hepatic vein. The caudate lobe may be supplied by right and left branch of this arterial supply, left and right branch of the portal vein. This CT image with a patient with liver cirrhosis, as we see, the right lobe is shrinkaged, but the caudate lobe is hypertrophied. Left lobe is normal, I think, because the caudate lobe has separated the blood supply from hepatic vein.
It's not separate blood supply, separate blood drainage.
Blood drainage from hepatic vein to the hepatic vein.
It has its own blood drainage into the IVC directly because the IVC goes through it immediately. The caudate lobe immediately drains into the IVC, separated from the rest of the liver. That's why when anything wrong goes in the left of the liver, the caudate lobe goes hypertrophied to compensate because it's a small liver separated from the rest.
Segment anatomy. I will talk about Conaud classification. It's divided liver into 8 segments, as we see, and each segment has own blood inflow and biliary drainage and outflow in the center of each segment. In the peripheral segment, there is a vascular through the hepatic vein. It will divide by right hepatic vein, middle hepatic vein, and falciform ligament and the portal vein. Right hepatic vein divided the right loop into anterior and posterior segment. The middle hepatic vein would divide it into 2 hemiliver, right and left, and the falciform ligament would divide the loop into medial segment and lateral segment.
The left divides the left lobe, medial and lateral.
Medial and lateral segment. The portal vein would divide the upper and lower segment. As we see here, the right lobe will divide it to the upper and lower segment. And the middle hepatic vein will divide it into the left lobe and right lobe. Falciform ligament will divide the left lobe into medial segment, this 2 and 3 segment, and lateral segment 4.
Lateral segment 4.
The upper part is segment 4A and the lower part segment 4B. Upper and lower is we talk about the portal vein. We divided the liver into the upper segments and lower segments.
Why it's important, this division? Why should we know it?
Because the surgical important.
It's surgical
when
important.
he enter the abdomen, he want to know which segment he will enter and remove resect the tumor.
First of all, each segment, as you said, has its own blood supply and the biliary drainage. So they can remove a segment as a functional unit. The whole segment can be removed as a functional unit without injuring the rest of the liver. First. Second, for localization purposes, when you say there's a mass in segment 4, everybody knows what segment 4 and where to look for the mass. Okay, for future imaging, for surgical intervention, for percutaneous intervention, treatment, whatever. Okay, so it is important for localization and for surgical resection.
And as we see segment 1, it's posteriorly, we can see it clearly in this picture. Transverse anatomy, look at this transverse plane in the upper part. So we'll talk about upper segments according to the portal vein. Is divided by right and middle hepatic vein and the falciform ligament. This is the middle and this is right hepatic vein. The middle, as we said, will divide the liver into the left and right lobe, and the right lobe is divided by segment 8 and segment 7 by this left right hepatic vein. And as we said, we are in the superior plane, so we are in segment 2 medially, not in segment 3.
When you have this, go back. When you have this like umbrella-like configuration, these 3 spokes, you know you are upper. So when you are upper, you have 8
upper segments.
The upper segments, which are mainly the segment 8, 7,
7,
okay, go
and 4, and
4 and
transfer.
2, okay, and you can know according to the hepatic veins which segment you are in. Okay, when you see this umbrella-like.
Lower plane, as we see here, how we know we are in the lower plane than the upper. The left portal vein began to appear, so we are in the middle of the liver. As we know, left portal vein is higher than the right portal vein, so we are in the segment 2 to 3 and 4A or B to B, and the middle. And we still in the superior, تقريبا superior segments, 8 and 7 segments. When the right portal vein begin to appear the lower plane, we are in the lower, تقريبا nearly the lower segments. So we are in segment 3 and segment medially, and laterally we are in the segment 4B, and in the right lobe we are in segment nearly 5 and segment 6 in the right lobe.
So the most lower segment is segment 6.
6.
Okay, and above it is segment 7, and medial to it is segment 5.
5.
جوا inferiorly, and above it is segment 8. Okay, يعني 4B 4A 5 8 6 7.
احنا اذا شفنا دكتور
From inferior to up superior.
اذا caudate lobe.
Caudate lobe is segment 1. هذا ما نعنى. It's separated from the rest of the lip.
الكوادريت لوب راح يفصل الاي فور A and B.
Sorry, caudate.
Quadri.
ايه ايش بي؟
separate the 4.
هو 4.
هو quadrant lobe
It
is
is
the 4.
segment 4.
قصدي separate in the left from the right.
No, يعني 4A
Before,
and
previously, they were dividing the liver into left lobe and the right lobe by the falciform ligament. They say the falciform ligament is the division between the left and the right. This was functionally incorrect. Okay, so they re-divided the liver into left and right lobe, separated by
hepatic veins.
the hepatic veins. Okay, so the lateral aspect of falciform ligament previously was with the right lobe. Now it's with the left lobe. Okay, يعني segment 4 previously كان right lobe. هسه now it's in the left lobe.
Because
Okay.
it's lateral to the
Functionally more
middle hepatic artery.
accurate. Yeah, exactly, just like this picture.
It's okay. I will. The arterial supply of the liver is mainly by common hepatic artery. It's one of the 3 branch of the celiac trunk, with the splenic artery and the left gastric artery and the common hepatic artery, which after giving the gastroduodenal artery, it become hepatic proper and divided into the left and right hepatic arteries. There is variation in the arterial supply of the liver is slight commoner than the variation in the portal vein. Hepatic artery normally passed anterior to the portal vein, posterior to the common hepatic. But we have accessory hepatic artery, which originate from the superior mesenteric artery instead of celiac trunk. As we see here, replace common hepatic artery. It arises from superior mesenteric. When we do angiography to the celiac trunk, we will see the splenic artery and the left gastric artery, but we didn't see any hepatic artery. But we did angiograph to the superior mesenteric artery. Here is the replaced common hepatic artery. It's about 2% of the people present.
What's the difference between replaced hepatic artery and accessory hepatic artery? What's the difference? And when you say replaced hepatic artery, when you say accessory.
not present يعني أصلا يعني.
accessory يعني
accessory
in addition to the
addition.
previous
Accessory is an
organ.
additional artery. يعني the original artery is present and accessory one super added. While the replaced is the original one is not present and it's originating from somewhere else. Get it?
Yeah. Replace common hepatic artery occur about 2.5% of the people. The entire this is normal picture, right? The common hepatic left and right. A replaced right hepatic artery occur about 10% of the people. This is superior mesenteric artery. This is the replaced right hepatic artery. This is the left also from the celiac trunk. It's about 10% of the people. Accessory replaced left hepatic artery occur also in replaced left hepatic artery in this picture occur in about 12% of the people. It arises from left gastric artery, not from the common hepatic artery.
Why this is important to know?
Because
What's the
sometimes we do angiogram and
So
we
بال-
color
embolization.
overs.
embolization is first. Okay, I would agree with that. What else? What are the clinical application of knowing the anatomy of the hepatic arteries? Let's see.
Surgical purpose يعني.
What's the question?
What is the clinical importance of knowing the variations of the hepatic arterial supply? Why it's important?
There is variation, there will be variation in the other systemic circulation.
About the liver, mainly the liver. Why it's important? The most important thing, first of all, طبعا okay, for intervention, for angiography, for liver embolization, all of these are important. But something that is very important, yeah, the hepatic arterial anatomy will be of paramount importance is the liver transplantation. When you are working with liver transplantation or in a center where they do liver transplantation, you're gonna have to report each and every artery from where it arises and where it ends and how long it is and how what's the diameter, because the transplant surgeon will depend on that to choose whether to take the left lobe or the right lobe or somewhere else or where to put it and how to suture it, and all these details will depend on your report. And the life of the donor and the recipient will be depending on your report. Not one patient, two. Donor who's healthy and the recipient who's sick. So, in addition to interventional purposes and surgical purposes, the liver transplantation will be of very big importance in this case.
Another variation, the common hepatic artery may divide it or trifurcate with the gastroduodenal artery. As we see, the gastroduodenal artery will arise from common hepatic artery, and after that will divide to the left and right. Some variation will be trifurcate, يعني, three branch from here. And the hepatic artery may arise directly from aorta, not from celiac trunk. Is another variation. Portal vein, as we said, it's less prone to anatomical variation. It's a portal vein formed behind the neck of pancreas at level L1 and L2 by joining of the splenic vein and superior mesenteric vein. And it will pass anteriorly to the inferior vena cava and enter the liver posterior to the hepatic artery and common bile duct, and it will divide into the left and right portal vein. Here's the inferior mesenteric artery. It will join splenic vein before it enter the before it joining vein. It will join the splenic vein before it joining the before splenic vein joins superior mesenteric artery. About 40% of people, this inferior mesenteric vein will drain to the superior mesenteric vein, and about 1/3 it will join in the confluence at the confluence. 1/3 of the people at the confluence
So
with
it might
the
drain
vein.
into the splenic vein, the confluence, or the superior
Or
mesenteric
superior
vein.
mesenteric
It can drain
artery.
here.
Portal vein and segmental anatomy. Portal vein we divided into the right anterior and right posterior portal vein. Anterior will supply segment 5 and 8, and posterior division will supply segment 6 and 7. And left posterior vein, left portal vein will supply segment 2, 3, and 4A and 4B. And also will drain the caudate loop. Caudate loop can drain to the left and or to the right portal vein.
Drain or supply?
Supply.
Supply. Not drain. Where does
Yes.
drain?
فينا بينا كاب الكاوديت لوب. Yes, it's important شوية. صح. Venous drainage of the liver. The liver is drained by hepatic vein. As we said previously, this is the right, and this is the middle hepatic vein, and this is the left hepatic vein. The hepatic vein, as we see in this picture, differs from the course of the portal vein and hepatic artery and the biliary drainage. It's completely different. And a lower group of small vein drain directly, as we see this caudate loop. A small group of the vein will drain directly to the inferior vena cava here.
In
it's,
case of liver
has,
cirrhosis, okay, if someone has liver cirrhosis,
Yes.
portal vein will have slower blood flow, slow, because portal hypertension. Come on.
That's right.
So the portal artery will be not affected, or smaller or larger, and why? When you have portal hypertension, mostly due to liver cirrhosis, the portal vein will have slow flow because liver cirrhotic, stiff, قوي. Okay, the flow يكون يعني أقل. Okay. What about the hepatic artery? Will it be the same? Will be not affected, or it will be larger, or it will be smaller?
In the caudate loop? No, in the
Hepatic
liver.
artery.
Hepatic
Eh.
artery in case of portal hypertension.
What do you think, Ivan?
Smaller.
Smaller. Ivan says smaller. What do you think?
I think normal.
Normal. Jinan.
خلي أفكر.
Marwa. Normal. See. ها فكرتي لو بعرف.
يعني أكيد يتأثر.
How?
راح يقلل البلاد سبلاي.
It will decrease. Okay. The liver is supplied by two major sources, portal vein and hepatic artery. Okay? They supply blood. Portal is vein, but it supply blood.
Yes.
Okay? Not drain. Portal vein supplies about 70%, 70-75% of the blood to the liver. Hepatic artery supplies about 20-25% of the blood to the liver. So, when you have one of them, which is the major one, the portal vein, incompetent, slow flow, low, there is cirrhosis, prevents blood flow in the portal vein. So the blood supply to the liver from the portal vein will be less. صح? So what do you think will happen to the artery? Compensation how? Will increase in size. It's not smaller. It's not smaller. It's not smaller. It is bigger. Okay? So when you have portal vein abnormality, usually you see the hepatic artery more obvious. تشوفها بالدوبلر أوضح وأكبر وأحلى وشي أحسن ومبين. Okay? Because he will be the star. Hi first. Hepatic artery. First. Second, when you have metastasis in the liver. Metastasis, tumor. Tumor يحب الأكسجين. Tumors loves oxygen because it wants to grow. تمام؟ يعني يحب يأكل. He likes to eat. So the oxygen is present more where, in the artery or in the vein?
The artery.
In the artery. The hepatic artery has more oxygen than portal vein. So the metastatic lesions, the tumors, the cancers will take most of its blood supply from the hepatic artery. That's mean, first, when you have a metastatic tumors in the liver, the hepatic artery will be larger because it supplies more blood. First. Second, what they do endovascular embolization. They go through the hepatic artery, through the aorta, celiac trunk, and from celiac trunk to the hepatic artery, and they inject particles, they call PVA, polyvinyl alcohol particles, okay, in the hepatic artery. They occlude the artery, cutting the blood supply to the tumor. Okay? What about the rest of the liver? The hepatic artery will be occluded. Why the liver is not affected? Because it takes 70-75% of its blood supply from the portal vein, which is no one touched. So the tumor loves the artery, liver loves the vein, the portal vein. So we occlude the artery and get rid of the tumor and leave the portal vein patent to supply the liver. مفهوم? Get it? Or not obvious?
vice versa is true.
Liver cirrhosis.
So
Liver cirrhosis. Makes resistance to the artery يعني increased resistance.
yeah, but the artery has high blood pressure. The artery has systemic blood pressure like 120 over 80, while the vein is very low pressure, not more than 20 millimeter. What?
And vice versa is true if
What
it is portal occluded and if this hepatic artery affected and portal vein will be compensatory will be large. Yeah.
Hepatic artery affect, what
Yes.
conditions affect the hepatic artery?
You have no this disease.
No, we can occlude the hepatic artery by endovascular embolization. The blood flow in the vein will be more.
Portal vein, hepatic artery there compensate the liver.
Usually you will go into liver necrosis because the 20% will be not be enough to supply the liver. Okay? Usually the patient will die. Because the hepatic the portal vein. Okay? Good.
Hepatic veins have no valves. Lymphatic drainage, there is a lymphatic drainage to the porta hepatis lymph node and to the retrobiliary lymph node and to the celiac trunk lymph node and to the cisterna chyli, and there is a superficial network of lymph node under the capsule of liver and anterior part of diaphragm and viscera, which drain into the deep lymphatics. Radiological feature of liver in the plain X-ray it will not be visible يعني in the border just in fatty obese person because in the
Just in Dolma
retroperitoneal
person, huh? Just in Dolma person.
yes exactly because it's
Fat and obese.
because of properitoneal fat, intraperitoneal fat, and omental fat and increase in obese and will make the border more obvious of the liver. In the CT abdomen, we will see the relation of the liver to the visceral organ, the right kidney here in this inferior section, right kidney, it is liver, right kidney, duodenum, and inferior vena cava. As we see this relation of the liver to this structure. Also we will see the segments as we said by division of inferior vena cava to the hepatic veins. This is left, middle hepatic vein and right.
The inferior vena cava does not divide into hepatic veins. The hepatic veins joins the inferior vena
joins
cava.
كل شيء أيوة بالliver كل and we see the left portal vein here and right portal vein in the upper section. MRI, normal MRI scan of the liver. Liver parenchyma show intermediate signal intensity and the blood vessel appear يعني has no signal as we see here the inferior vena cava and the aorta. This is the liver.
Where's the division? You didn't explain us. Where are the segments? By the CT.
Segment by CT.
Come on. This is the
didn't
main
find
the most important slide of the whole lecture.
Go back. شوية difficult يعني.
No, go back. So, where is the upper part of the liver?
This is the upper part.
When you
of
see
the
the
liver.
umbrella-like
Yes.
abdomen lesion, appearance. So, where you have the right side, the right hepatic vein. Where's the right? This is the middle. Where's the right? This is the
This is
right.
the right
So everything posterior to it is segment what?
we are superiorly, so
So?
it is 7 here
Okay.
and 8 here.
Okay. So what's difficult? It's not difficult.
Not difficult.
Okay.
لا قصدي
And
details يعني.
What's next? The middle hepatic vein.
4A
4A.
and this
superiorly. And then
superiorly and segment 2 here
2.
in the left.
Excellent. Go a little bit down. Where is down?
يعني portal vein يعني 2 of the branches are
Okay.
visible.
So
We are
tell us, what do you see?
يعني nearly segment 6 and 7 here
Good.
and segment 8
Which
and
one is
5.
upper and which one is lower?
This
Six lower.
Six
lower,
lower,
seven.
seven upper,
Good.
and segment 5 and 8 superiorly here.
And the mid part
تقريبا
is
nearly
8 up and 5
and 5
down.
down.
And then you have
segment 4A,
4A up and
up and
4B
4B down,
down.
and
You have segment 2
2
up.
to 2 to
and
3 and
three.
up to 3 here down.
Okay. Go to the most lower part of the liver,
Lower,
which is this one. Okay.
it's right kidney.
Right kidney. So what do you see next to the right kidney?
يعني inferior vena cava and
What
duodenum.
segment of the liver?
lower,
The lowest part?
6
So
6 and 7 يعني
6,
7
7,
superior
4.
7 and 6 lower.
So is it difficult?
No شوية
Come
يعني
on.
I have to think.
Yeah.
Thank you, Dr.
Continue.
Rayan.
Work.
I said about MRI, it's an intermediate intensity and anechoic vessel. Ultrasound, all of us know about ultrasound, but there's a few hints in ultrasound.
Yeah, hint بالultrasound.
There's the ligamentum venosum to know the caudate loop can be seen here. This ligamentum venosum, and this is the inferior vena cava. Between them is the segment 1 is the caudate loop.
Yes.
As we see, that's the ligamentum venosum, and we are posteriorly, not anteriorly. The ligamentum teres, as we see here, transverse plane and sagittal, is a continuation of left portal vein, and it will separate it quadrate loop here, as the segment 4.
Okay.
As I know يعني. It's separated segment 3 and 2. يعني it's medially segment 2 and 3. I know. What's your comment?
There's something wrong here, but I'm not sure what is it. Anyway.
I'm fast.
I'm so nervous أذكر دكتور بس أقول فشي داري مداير يعني بسرعة عامة يعني رفلي داري مداير جول بلادر what are the segments
Gallbladder bed is segment 4.
okay
Okay. Between the IVC, when you see the IVC adjacent to it is segment 1, the coded.
yeah
Okay.
okay
So just as a general
yeah,
idea. Okay. Next.
Hepatic arteriography is achieved by aorta or celiac trunk with a greater selectivity if contrast inject into the origin of the gastroduodenal artery, and the frequency of variation may make injection into the superior mesenteric, as we said before, and the left gastric artery may be necessary.
Wait. Hepatic arteriography, you inject contrast where?
Celiac trunk and
Okay.
aorta, but sometimes we have to
First
inject
of all,
superior mesenteric.
they start by injecting contrast in the aorta
Yes.
to see where is the celiac.
yes
When they see the celiac, they go into the celiac and inject contrast into the celiac to see the hepatic artery and its branches and stuff like that. Okay. After that, when they do the celiac, if they saw the left and right, it's okay.
Okay.
Now it's time to look for accessory arteries.
Yes.
Then they go to the gastroduodenal and
Maybe-
the superior mesenteric to see if they give other branches.
Yes.
فهمنا؟ تمام.
Hepatic arteriograph, as we see here, common hepatic artery will give gastroduodenal artery and become proper hepatic artery. This left trunk and this is the right trunk. Portal venography is direct injection of into the portal vein at other operation, or injection to the splenic bulb, splenoportography. The first method is quite direct, as we see in the intra-operation.
That's no one do that.
It's old method.
You want me to go into the spleen and inject contrast in the spleen, which is highly vascular and might rupture just to see the portal vein?
It's replaced by MRC.
Why?
It's hepatic venogram. Retrograde may be also used, and not
Hepatic
used.
venogram. How do they do hepatic venogram? Do you know?
يعني I don't know.
الانفيريور فينا كافا
How?
no from the internal iliac
You have two options. Either you go from the femoral vein,
yes
it's
Yeah.
usually little bit into the IVC and then try, or most of the times they do hepatic venogram for the purpose of TIPS, for transjugular intrahepatic portosystemic shunt. So since TIPS is usually transjugular by its name, transjugular intrahepatic portal system, by name it's transjugular. They go from the internal jugular into the IVC, and they, طبعا, keep in mind that blood drains from the liver into the IVC and out of the liver. So when you inject contrast will يرجع عليك, will go back. It will not go into the liver. So they have to inject very strong just to see a little bit of contrast. Maybe goes for half a second into the liver. It's not like the arterial, very easy. The venous is much more difficult because you inject and the blood comes back to you. يعني تخيل صوندة ده تطلع مي وانت تريد تدخل مي داخله وهي مفتوحة ده تطلع مي عليك. It's very difficult, okay?
Gallbladder, the biliary system, the gallbladder is a pear-shaped organ. It has a fundus and body and the neck of the gallbladder, and also has cystic duct which has a smooth part lower, and the proximal part which has a multiple mucosal fold, which is spiral valve of Histar, and proximally we have a pouch. It's called Hartman Pouch. It's يعني تقريبا not normal. It's seen when the gallbladder is dilated only. The gallbladder length is about 10 centimeter and the diameter about 3 centimeter. The relation of the gallbladder, as we see anterior superiorly, the gallbladder bed anterior superiorly, and is related to the anterior abdominal wall at the point where the lateral
Again?
anterior abdominal wall fundus.
Yes. Is that to the anterior abdominal wall? You are pointing to the body. The body
لا
is not
البودي
related to
يعني
the abdominal wall.
gallbladder bed in the liver.
Okay.
But anteriorly the fundus related to the anterior abdominal wall where the rectus muscle meet the 9 costal cartilage, يعني right costal muscle. Posterior inferior related to the first part of the duodenum, and the fundus related the يعني body, but the fundus related to the transverse colon, and the neck is related to the lesser omentum, not appear in this picture. Normal variant of the gallbladder, the lumen may have septum, the fundus may folded back on itself. It's formed what's called pharyngeal cap. Pharyngeal cap.
Pharyngeal. شايف هذول السنافر Smurfs
ايوه
cap.
Diverticula may be seen anywhere, common at the fundus. And location may be retrohepatic or suprahepatic. Location may be intrahepatic, normally which is normally in the fetus up to 2 months. Location may be left-sided. If it's left-sided, it may be under the left lobe or herniated through the epiploic foramen as a part of transposition of the viscera. Sometimes the absence of the gallbladder is very rare, and double gallbladder, which exceedingly rare, but if double, it will have share common cystic duct.
Just a funny story. A few months ago, some surgeon, he had a patient, acute cholecystitis, removed the gallbladder, and that's it. Everything was done. After a while, the patient comes with pain and jaundice and things like that. He sends him for MRCP, and the gallbladder is there. Okay?
Double.
السيرجن يحلف 100 يمين I removed it by myself بإيدي ذبيتها بالزبر. شنو you say there was another gallbladder that was completely intrahepatic, cannot be seen during surgery. It's within the liver buried, and also it has stones. The other gallbladder, so it was a very nice case. They have removes a gallbladder and there's another one buried inside that no one can see it. And they shift him to the hepatic surgeon and the patient to the liver surgeon, and I don't know what happened after that.
Arterial supplies the gallbladder. Gallbladder is supplied by cystic arteries, a branch of right hepatic artery. Bile ducts, intrahepatic bile duct follow the same pattern of distribution of hepatic arteries as the artery with the segment. It's divided to the right and left bile duct. Right one is have anterior and posterior. The anterior division more anterior, more horizontal than the posterior. The anterior is supply segment 5, 6, 8.
Drain segment 5, 6, and 8.
Drain. The posterior division will drain segment 7 and 5, and here the left hepatic duct, which is drain segment 2 and 3, and segment 1 and segment 5. Segment 1 can drain to the left or right, and it will course for 3 to 3.5 centimeter before it join the cystic duct, where it and the right and left biliary duct, hepatic biliary duct will measure 3 centimeter, and the common hepatic duct will measure 7 centimeter.
What?
Millimeter. I'm
Millimeter
so
in-
fast because it's 9 hours now.
Don't worry. Just continue. Still have time.
The relation common hepatic duct line anterior, as we know, to the portal vein in the free edge of the lesser omentum. As I said before, it has a course 3.5 centimeter before joining the cystic duct, and the common bile duct have a supraduodenal third and retroduodenal third, and pancreatic here we can see here third.
Yeah,
common
one
common
third of it is supraduodenal, one third is retroduodenal part. They should say supraduodenal part, retroduodenal part. Okay.
common
And just where is it located?
high supraduodenal, retroduodenal, and pancreatic third. Supraduodenal part is run anterior to the portal vein, and is the hepatic artery on the left side in the supraduodenal, and will run in the lesser omentum edge. In retroduodenal, it will groove in the posterior first part of the duodenum with the gastroduodenal artery here, and the pancreatic third will pass behind the head of the pancreas and make a groove toward the midpoint of second part of the duodenum, where will join the where it will join the male pancreatic duct and the ampulla of water, and will open into the second part, and there is a two-fold of mucosal fold around the opening, which make it easy to identify at endoscope. يعني papillae 8 to 10 centimeter distal to the pylorus ampulla. Variation in the biliary duct. Some variation in intrahepatic duct occur about 40% of the cases. This vary more often than extrahepatic duct. The commonest variation are shown, and when the right posterior duct may drain to the left, not to the right, before it confluence with the right distal right anterior duct. This is a commonest variation. This is the commonest variation. This is the normal, where the right posterior join the right anterior to form right hepatic duct, but the variation is the right posterior join the left hepatic duct, not the right one. It's the most common type out. There's multiple also rare variation here at the confluence right posterior duct, or may join the left to form common trunk. Variation in the cystic duct cystic duct may have low union with the hepatic duct, may adhere to the common hepatic duct, or have high union with the hepatic duct. Cystic duct may be absent or very short, anterior or spiral joining common hepatic duct, posterior spiral joining common hepatic duct on the left side. It's common. It's on the right, but the variation on the left. Radiological feature of biliary system. We don't see the gallbladder on the in the abdominal X-ray, just in when there is pneumobilia, air in the gallbladder, which happen after sphincterectomy, and or in the elderly where ampullary tone is low. Sphincterectomy. Removal of sphincter. After surgical anastomosis of bile duct to the small bowel, choledochoduodenostomy. This is a pneumobilia. And we can see it also when there is a calcification and when there is a gallbladder stone, but normally not appear. On the ultrasound, as we know, the gallbladder wall is seen at a thin echogenic line less than 3 centimeter. We have some hints here. There's a spiral valve of Hister which appear slightly echogenic. Sometimes it's diagnosed as a gallstone, but it is a spiral valve of Hister.
So be careful. Not everything that
Give acoustic
is
shock.
white at the neck of the gallbladder is a stone. It might be the valve of Heister. It might be normal. Be careful.
And the upper limit of normal common bile duct is approximately 1/10 of the age. When he's 40, the upper limit 4 millimeter. When he's 70, the upper limit is 7 millimeter. And this is the common bile
Not
duct.
more than 7 millimeter.
According to the age.
They
30 is 3 millimeter, 40 4
بس
millimeter,
رجع
50 5 millimeter. Although
The valve of
بالfundamentals يقول لا ما كل شيء بس we know that.
دكتور هاي البورتا هيباتس فيجر 5
Sorry.
عندنا البورتال فين والكومن بايل دكت اند
Hepatic artery.
هيباتيك ارتري. الكومن بايل دكت راح تكون البورتال فين posterior to the
Posterior.
common bile duct
Yes.
والهيباتيك ارتري راح يكون
والكمون
left.
bile duct ثنتهم anterior.
يعني
الارتري will be on the left and the bile duct will be on the right.
I think at this picture الارتري at the right.
You need
This
color
is
Doppler
longitudinal
to see to
picture.
know where is the artery.
ما اعرف يعني.
You need color Doppler.
Contrast examination. A variety of contrast examination such as intravenous cholangiograph and oral cholangiocystograph and has been replaced by ultrasound. Others such as MRCP has replaced ERCP as a first line investigation of intra and extrabilary tree. This is the ERCP, this is the endoscope which enter the duodenum and this is the pancreatic duct. This is the common bile duct, this is the left hepatic duct, and this is the right hepatic duct. MR cholangiopancreatigogram, it analyzes the long T2 relaxation time of static fluid, heavily T2 weighted static fluid, heavily T2 weighted fat suppressed sequence produce image where the static fluid in the bile duct and pancreatic duct is hyper intense and background is suppressed. We see here MR cholangiopancreatigogram. This is the gallbladder, this is the duodenum, this is the confluence of to form a common bile duct. This is the pancreatic duct, and a hint about the liver: it has the renal loop, as a fair tongue-like projection of right loop.
لا umbrella بالاكزيال.
Axial.
Okay.
And this picture also the pancreatic duct and the common bile duct. And finally I have CT of biliary. I didn't find many picture and
You
I
will not find
understand.
things
I
a
don't-
lot of biliary tree. You may find some
It's
dilatation,
also-
some pneumobilia. That's it, no more. Okay, next.
it's final slide.
Good. Thank you very much.
Thank you very
Thank
much.
you.